This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 65-year-old lady is posted for cataract surgery, and on the day of the surgery, once the pupil is dilated, I'm seeing this case, and there is one striking feature which has caught my attention, that is, the chamber is extremely shallow. The lens appears as if it is bowing anteriorly. The peripheral antechamber is very shallow, the iridocorneal touch is there, and the pressure which was checked after dilatation was in the early 30s. Before dilatation, the IOP was 18. So curiously, I had a look at the other eye. The other eye was alright. The chamber was not as shallow. And with this picture in mind, I thought this is probably a primary angle closure disease because the disc was still normal. So the disc appeared normal and the angles were closed in this eye. But surprisingly, the other eye, the angles were not as narrow. I could still see the pigmented tubercular meshwork in more than 180 degrees in the other eye. On the contrary, the affected eye had a 360 degrees angle closure. And this is the anterior segment OCT picture of the angle and the lens. The striking observation here would be that the entire lens iris diaphragm appears to have shifted anteriorly. But mind you, at the slit line, there is no evidence of any phacodonosis. So it was a little bit of a peculiar thing. Anyway, I decided to postpone the surgery. So we did an iridotomy after a couple of days. Patient was on anti-glaucoma medications. The pressures were normal. We rescheduled the surgery again after 1 week of laser iridotomy, and this is the slit lamp picture on that particular day. The chamber is relatively better, but still it is shallow. I can still see that the lens appears to be bulging forward, and the distance between the iris and the cornea seems to be much more than what it was before doing the iridotomy. On retroillumination, this is how the iridotomy looks like, and it is patent. We did the intersegment OCT and the angle assessment post-iridotomy. The chamber depth had significantly increased by around 600 microns, and also there is a significant improvement in the angle opening. So let's begin the surgery. The surgery is being done under peribulbar block with IV mannitol having given. We have a soft eye. So remember that at the slit lamp there is no evidence of phacodonosis suggestive of weak zonules, but at the back of my mind, looking at the other eye picture, it looked to me like the zonules could be compromised, and that's the only reason why the entire lens diaphragm is shifted anteriorly. So I'm going in with all my plans ready in case of a zonular weakness, which if I happen to notice intraoperatively, I have got my capsule hooks ready, the CTI ready, and all the other armamentarium. So as soon as I touched the capsule, I could see the wrinkling of the intercapsule, and the wrinkling is quite extensive, and this is confirmatory that the zonular weakness is quite significant. As I'm tearing the capsule, I can see that there are folds appearing near the tearing edge of the rhexis margin. Creating the rhexis was not very difficult, but one critical factor which I was focused on was to ensure that the rhexis is not more than 4.5 to 5 mm, because at this stage my options of fixing the lens are very limited. I am considering using the IOL trap technique with the hydrophobic multipiece lens, the haptics being in the sulcus and the optic in the bag. So for that, sizing of the rhexis becomes extremely critical. Thankfully, the rhexis went according to plan. I have a well-centered, appropriately sized rhexis. Hydrodissection is probably the most important step here because I cannot proceed further unless and until the corticocapsular adhesions are broken. A gentle rotation attempt is sufficient enough to tell me that the hydrodissection was not effective and we need to stabilize the bag. So what do I do next? My usual options would be use the capsule hooks or the CTR. Which one to go first? Usually I go with the CTR, but in this case, looking at the enormity of the zonular weakness, I thought I will go with the capsule hooks first instead. I make 4 small paracentesis incisions which are posterior limbal based, and these capsule hooks, which are made by Madhu Instruments, are inserted into the antechamber. I usually would like to place all the hooks first in the antechamber, and when all the 4 hooks are there, then I would like to engage the capsular bag one by one. Care is to be taken not to overstretch the capsule, and I'm mindful of that. Once the bag is stabilized, I want to redo the hydrodissection. With the bag being held taut, the hydrodissection would be much more effective. So now the corticocapsular adhesions are broken, the lens is freely mobile. Now is the time to perform the phaco emulsification. At this stage, I noticed that the capsule hooks are disengaged. So I need to go in and re-engage them and also re-tighten them a bit. The strategy of nucleus management is to do the vertical chop. Divide the nucleus into multiple smaller fragments and then emulsify them one by one. The nucleus density is not very high. It's about grade 3 nucleus, so dividing the nucleus is not a problem. The only problem is when you're trying to do the lateral separation, since the zonular health is not so great. The lateral separation maneuver takes a little bit of extra effort. During all these maneuvers, I need to be mindful that caution has to be exercised at every step. I need to be as gentle as possible. The process of dividing the nucleus is continued until I have about 6 small fragments. The visualization is not great, I must confess. Maybe because the capsule staining was not done very well. So during the chopping maneuvers, I need to be very mindful that the chopper does not go in and hit the rhexis margin. Once the fragments are divided, time to emulsify them. I'm going in and removing these small fragments out of the bag and then emulsifying them one by one at the rhexis plane. Because the emulsification is being done a little bit more anteriorly, I need to refill the chamber with OVD so that the endothelium stays protected. See, as soon as the capsular bag is stabilized, you realize that doing surgery seems almost like normal. In such situations where there is significant zonular weakness, I would think that it is worthwhile to go in and hook the capsular bag. It makes the surgery safer and also more efficient. Time to remove the cortex. And at this stage, the cortex is being aspirated. I suddenly see there's a posterior capsular fold here. And also, there is a displacement of the capsular bag on my left hand side. I can clearly see the edge of the capsular bag, and this is possible only if something is pushing out. And most likely, this is the vitreous, which has prolapsed transzonularly. So at this stage, I'd like to stretch the capsule a bit, so I'm going to introduce the CTR into the capsular bag. I'm hoping that by keeping the bag stretched, the prolapse of the vitreous could be limited in that particular area. Before putting the lens, I disengage the capsule hooks, extract them out of the eye. I want to ensure that the vitreous is taken care of before I would like to go in and put the lens in. So diluted triamcinolone acetate confirms the presence of the transzonular vitreous fibril in that area. At this stage, I need to answer the couple of questions in my head. What should be the plan of doing antivitrectomy, a pass plan approach or a translimbal approach? Now, because we know that the vitreous is prolapsing from behind and across the zonules and not through a posterior capsular tear, I would like to go ahead and try the pass plan approach. Although initially I thought, let me try the translimbal approach. So when doing the translimbal approach, one has to be very mindful of not cutting the iris, pupillary sphincter and the rhexis margin, because we'll be working very close to that edges. And the rhexis margin is probably the most sacred part for us, because if we don't have the rhexis intact, then sulcus placement of the lens will not be possible. I did try the limbal antivitrectomy in this case, but I realized that this strand was very difficult for me to remove. So eventually I decided to go in and do the pars plana approach for vitrectomy. 3 mm from the limbus, MVR blade is used to create a sclerotomy port. This port is created by directing the blade directly towards the midvitreous cavity, and now is the time to perform the vitrectomy. So as I'm introducing the cutter, it is important for us to realize that the bevel has to be down when I'm entering the eye, and always directed posteriorly towards the midvitreous. When you're trying to do an anterior vitrectomy through the pars plana approach, we need to remember what can go wrong. The most unwanted complication would be the PC tear. The vitrector can inadvertently catch the posterior capsule and tear it. This can happen especially for anti-segment surgeon, because we are not used to the pars plana approach and our depth assessment might not be great. So inadvertently, there's always a risk of the cutter chewing on the posterior capsule. So I need to be mindful and to keep a safe distance away from the posterior capsule. The cutter is always held steady at one place as the cutting is going on. Just observe that there is no irrational moving of the cutter. It just stays at one place. So as cataract surgeons, we might be inclined to move the cutter left, right and center, but being still is the most important principle to be followed. Just be there until the entire zone in that particular region is taken care of. Once that zone is finished, you can always move the cutter to the adjacent area. In a few minutes, the vitreous which had prolapsed out through the zonules is pulled down, cut and aspirated. However, there is still some amount of transzonular vitreous coming from another area which needs to be dealt with. This is dealt with the anterior translimbal approach. After some time, I can confirm that there is no more vitreous in the antechamber. Time to implant the lens. Let me remind you that it's worthwhile to extend the incision a little bit wider in cases where vitrectomy has been done because the eye would be very soft and navigating the cartridge can be a little bit of an issue. Cohesive OVD is used to create space in the ciliary sulcus. So we have enough space between the iris and the anterior capsule, and the lens, which is a multi-piece hydrophobic lens, is gently navigated. The distal haptic goes in first, followed by the proximal haptic, and now both the haptics are now dialed in and they are in the sulcus above the anterior capsule. So at this stage, both the haptics and the optics are in the sulcus. I want to check for any vitreous remnants before achieving the optic capture. Diluted triamcinolone acetate is injected one more time just to ensure that I'm not missing out on any vitreous fibril. There is a hint that there could be some transzonular vitreous still present. The pupillary shape gives away the clue. So I go in and perform the vitrectomy very carefully not to damage the sphincter pupillae. The key to achieving success in such a situation, when you're working very close to the iris margin and the capsular margin, is to ensure that the flow rate and the vacuum are set very low. So in this case, the flow rate is set as just 12, the vacuum is 200, the cut rate is about 5000, and it's a linear mode. So if you keep your flow rate low, it doesn't attract any tissue so that you can cut without inadvertently chewing on to the iris or the capsule. So now the OVD and the vitreous has been taken care of. The OVD in front of the lens is now aspirated out. The vitrectomy port is sutured with an atovicral suture. Time to perform the optic capture. With the irrigation in my left hand side, the lens is pushed back gently so that we can see the optic sliding behind the rhexis margin. And now ovalization of the rhexis confirms that the optic is well and truly captured. The side ports are hydrated. Because the eye is softer post-vitrectomy, I would like to close the main incision using a 10-0 nylon suture. The conjunctiva is closed using glue, and this is the end of the case. Now, these are the first day post-op pictures. The cornea is edematous. However, the chamber is deep. There is not much of an anterior chamber reaction as such. And this is the anterior segment OCT picture, both pre and post-op. This is how the anterior segment looks like. There is a dramatic change in the appearance of the depth of the anterior chamber as well as the amount of angle opening. There is small DMD near the wound. Now this is the third day post-op picture. The patient's vision is significantly improved. The edema has decreased. IOP without medication is 16 mm, and this is the anterior segment OCT at the end of 3 days. So the patient continues to do well. To summarize, this was a very unusual case where we had an angle closure like disease, but it was secondary to the anterior displacement of the lens iris diaphragm because of zonular laxity. So a few lessons to learn from this case. Number 1, absence of phacodonosis does not mean that there cannot be zonular weakness. Number 2, lax zonules can push the lens iris diaphragm forward, resulting in an angle closure mechanism. And number 3, appropriate technique to stabilize the bag intraoperatively will ensure good outcomes. And when you have a transzonular vitreous prolapse, we have to weigh in the option of translimbal versus the pars plana. If the visualization is great, the pars plana approach is probably the better way to deal with the transzonular vitreous. And lastly, fixing the IOL. The IOL trap technique would be a better way of ensuring long-term stability of the lens bag complex. So that was it. Thank you for watching and hope you found this helpful.